All right. Well, thank you for coming. My name is Scott Bovelsky. I'm a board-certified gynecologist here at the Villages Health. And my goal for today is to talk to you about some gynecologic conditions, especially ones that you would see out here in the villages. And let me get it there. There we go. So what we're going to talk about today, we're going to start with prolapse. So as women get older and you've had babies and things get a little weaker, things start to drop down a little bit. So we're going to talk about what prolapse is and how we can treat it, specifically bladder prolapse, rectum prolapse, and uterine prolapse. Also want to address some female cancers, the main ones being cervical, uterine, or endometrial, same thing, and ovarian. Then I also want to talk about menopause. So this is very common. There's lots of misinformation out there about menopause. So we want to get some of that straight, as well as incontinence. Incontinence is very common around here, but nobody talks about it. So there really are two types of incontinence called stress and urge incontinence. And we want to go through these because they're completely treated differently. So let's go over some anatomy here first, so you know what we're talking about. So this right here is the vagina. Cervix is here. This is what dilates when you have a baby, gets about 10 centimeters. We do pap smears. That's where we're doing the pap smear. We're screening for abnormal cells of the cervix. This lining right here is the endometrium. And premenopausal women who are still having their cycle, this gets thicker every month. And then when you don't get pregnant, it sheds and you have your period. So this is the uterus, fallopian tubes on each side, and your ovaries. The ovaries contain the eggs. And, you can get vaginal issues too, like a vaginal cancer, but that's very rare. So let's talk about pelvic organ prolapse. So over here on the left, if I were to cut you in half from top to bottom and look at you from the side, this is what you would look like. This here is the pubic bone in the front. This is your bladder where you pee from. There's the vagina, cervix, and uterus. Now, if you've had a hysterectomy, it's just the pouch here. Here's the rectum where you move your bowels. Here's your backbone, and here's your bum. Now, I'm going to show you a picture over here and on the next page of what I mean with prolapse. So prolapse is a weakness in the tissues surrounding these organs. This here is uterine prolapse. So as you can see here on the left, the uterus is at its normal position. And over here on the right, it is prolapsed down, so your cervix is all the way down here. This is kind of the same picture. It looks a little differently. Again, pubic bone in the front, backbone. And this is what's called a rectocele. So instead of being a straight shoot coming down, you have a little prolapse of this area of the bowel. Now, the key thing to remember is this is not the bowel falling out or the bladder falling out. So nothing is going to hurt you. This is just pushing the wall of the vagina down. So people always worry about their bladders going to fall out. It's not going to fall out. It's just a weakness in these tissues, and you can get this bulge that you will feel. So the uterus, when it's falling down, or the rectum is falling down, that's called a rectocele. If you have the bladder falling down, that's called a cystocele. You have muscles, ligaments, other tissue that hold up the uterus, and as you get older, they get weak. And as you've had babies, that injures it. So what are risk factors? The biggest risk factor is really pregnancies and vaginal births. The more vaginal births you have, the more likely you are to have prolapse. Now, I do have plenty of people who will have prolapse and never had babies, but that is a big risk factor. If you've had a really large baby, 9, 10 pounder, that is certainly going to increase your risk. Any kind of thing that will put pressure on your pelvic floor. So pushing down, lifting, straining, coughing. I see this a lot. Bad constipation. If people have really bad lifelong constipation and they have to push, it's going to weaken that tissue. There is a genetic predisposition to this. So certainly if you have kind of a family history of people having prolapse, your tissues may not be as strong as other people. So that's going to be a risk factor. What are the symptoms? So when people come in, they basically say, I'm sitting on a bed of rocks, or I'm sitting on a small ball. They feel this pressure in between their legs, and it's uncomfortable. Sometimes you can have pain with intercourse. It can cause you over time to get what we call overactive bladder, which we're going to come back to, where you have to go, gotta go, gotta go. Sometimes you can even get the whole uterus and cervix hanging out. And when it does that, it gets dry and gets irritated, and you can actually get some bleeding. So what can you do? There are some things you can help to prevent it or to make it less of a problem. Kegel exercises, most people have heard of. And in a Kegel exercise, you're basically squeezing your pelvic floor muscles. Just like working out your biceps or your rotator cuff, if you can squeeze your pelvic floor muscles on a regular basis, you're going to strengthen those muscles. That's going to give you more support. Prevent constipation. High fiber foods. People drink Metamucil. I don't particularly like that stuff, but there are fiber one brownies, fiber one bars, plenty of fluid. Prevent the constipation, you prevent the pressure. Any heavy lifting, avoid weight gain. This is, if you're morbidly obese, this certainly makes it worse. The key thing to remember about prolapse is that it's not going to hurt you. It is not like having a heart attack going into the hospital, and if we don't do something, you're going to die. This is a lifestyle issue. So sometimes the best thing is to do nothing. If patients come in and I reassure them that, hey, this is not going to hurt you, your symptoms aren't that bad, just leave it alone. Now, if your symptoms are bothering you and it's interfering with your daily activities, you do have several options. One is called a vaginal pessary, just basically like a little rubber donut. You come in, we kind of try to get the right size. It's got to be just right, like Goldilocks. It's too big, it's uncomfortable. If it's too small, it falls out. 90% of people, we can get a pessary in. And that is something you can do to avoid a surgery, and it takes away those symptoms. Lifestyle changes, so weight loss, avoiding heavy lifting, chronic cough. If you can avoid that, that's going to help. Now, if all of this does not work, there are surgical options. There's what we call vaginal repair, where you can push the top of the vagina back up or the bottom of the vagina back down. And people call that kind of like a lift, so to speak. It's like a tummy tuck for the vagina, and it puts things back in place. Now, sometimes you need a little bit more than that. So if the uterus is falling down, you really have to have that uterus taken out and then the top of that vagina put back into the right place. So it's not the most minor of surgeries. So I always tell people, try the pessary first. It doesn't work? Well, you didn't waste anything. And then if that doesn't work, then we can do the surgery. So what about cancers? So there are three main gynecological cancers. Again, this is our picture. So vagina, cervix, uterus, tubes, and ovaries. So cervical cancer is just of the cervix. So right here, that's what we're screening for with pap smears. Endometrial cancer is in the lining of the uterus, and then ovarian cancer is obviously of the ovary. So cervical cancer we're going to start with, as I said before, is a cancer of the cervix, which is the lowest part of the uterus. It occurs there because of the unique way the cells come together. So it occurs mostly in older women over the age of 30. However, I have seen it in younger women. And this is basically a completely preventable cancer. If you do your pap smears and you get the right follow-up, the chance you're going to get cervical cancer is as close to zero without it actually being zero. So there are certain risk factors. All cervical cancer, 99.9% anyways, is caused by a virus called HPV, human papillomavirus. There's a lot of misinformation about this type of virus. So every woman that's had intercourse has been exposed to this virus. Technically, by the book, it's an STD, but you can't think of it like that. because everybody has been exposed at some point in their life. This is not like a gonorrhea or chlamydia or somebody's been cheating on you or something like that. But, 20 years ago, we didn't know about HPV. Now we know that HPV can integrate itself into your cervix and over a 15 to 20 year period can turn into precancer and cancer. So risk factors are exposure to certain types of HPV, not all of them. Not getting your pap smear doesn't necessarily increase your risk of cervical cancer, but it just increases your risk of detecting it. Anything that decreases your immune system, such as smoking, if you're on medicines for rheumatoid arthritis or HIV, that can cause a problem. Multiple sexual partners, that really refers to being exposed to HPV. So it's not that having sex with multiple people itself is a problem, it's that you're more likely to get exposed to HPV. There may be some of you out there that your moms actually were given DES when you were in your mom's belly. Those people are becoming less and less because we don't use it anymore. But if you have been exposed to DES, that's a completely different type of cervical cancer, and those people need to be screened as well. So what are symptoms? The thing with early pre-cancer are there are no symptoms. That's why we do the pap smears. When you do get cancer, typically women will come in with really heavy bleeding or postmenopausal bleeding, and we go in and we look at the cervix and there's a big mass on the cervix, and that's cervical cancer. So anytime people have abnormal bleeding, especially bleeding after menopause, always need to come in. Sometimes you can get vaginal discharge or pelvic pain or pain during sex. Certainly, cervical cancer, as it starts to develop and get bigger, it has kind of a, nasty discharge that will happen. So any kind of abnormal discharge, pain, especially bleeding after menopause, you definitely need to come in. We talked about ways you can prevent it. So do pap smears. The younger women out there, there's actually an HPV vaccine. It's the first vaccine against cancer. It's really quite remarkable. So you want to give this to the young girls, and we give it to boys now too. You want to get it in their system and get them vaccinated before they're ever exposed to HPV. And what that does is if they do get exposed to HPV, it prevents that virus from integrating itself into the cervix. Other things you can do is don't smoke, use condoms during sex, limit your number of sexual partners. Now, I do want to tell you one thing. We do pap smears completely differently than we did before. So over the past 10 to 15 years, we have learned that the pap smear by itself is actually a bad test. It has a very high, what we call false negative rate, which means the pap smear comes back normal, but there really is a problem. The only reason the pap smear ever worked was eventually you would get an abnormal, and it takes 15 years to get cervical cancer. Nowadays, we do a pap and an HPV if you're over the age of 30. And then we do them every 5 years. You don't need them every year. The chance to go from a negative pap with a negative HPV test, so to go from there within 5 years, the chance of getting precancer, not even cancer, is only 0.18%. So the current recommendation is pap and HPV over the age of 30 every 5 years, and then we stop at 65. If you haven't gotten cervical cancer by 65, it's just not going to happen. So the PAPs detect abnormal cells. We can treat them. So it's 100% treatable. If your pap smear does come back abnormal, we may do something called a colposcopy, which is where we take a microscope and look at your cervix, and then we do biopsies to see if there's anything there, and then we treat it afterwards, which is actually really easy. It's when you get to the cancer that it's a problem. So if you do end up with cancer, there are basically 3 forms of treatment. Radiation, which they can do high dose to the cervix, chemotherapy, which kills the slow growth of cancer cells, and then a surgery. It depends on the stage of your cancer, depending on what treatment you get. So let's shift a little bit to endometrial cancer. This is a cancer of the lining of the uterus. This is the most common one I see. In fact, here in the villages, because of the age population, I see this all the time. So typically it's postmenopausal bleeding over the age of 50. Almost all these women are obese. or they're taking estrogen without progesterone. You should never, if you have a uterus, you should never take estrogen without progesterone. The unopposed estrogen can cause the lining of your uterus to turn to cancer. There are some women that take a medicine called tamoxifen for breast cancer, and this does slightly increase your risk for cancer of the uterus, so we have to follow them. And certainly endometrial cancer, the majority of it is not genetic, but some of it can be. So if you have this history of uterine, colon, or ovarian cancer, then we tend to evaluate people for any kind of genetic issues. Usually occurs after menopause, and almost always the number one symptom is postmenopausal bleeding or spotting. So the takeaway here is if you have any postmenopausal bleeding at all, even a spot, has to be evaluated. It is considered endometrial cancer until proven otherwise. Most of the time it's not, but you want to pick that up early. This is one of those cancers that if you pick up early, it's an easy fix. You have a hysterectomy and you're done. You don't need chemotherapy, you don't need radiation. Some people, when it tends to progress a little bit more and they show up at a later stage, can have these other issues like pain in the pelvis, problems emptying your bladder, or pain during sex. So there's no known way to 100% prevent uterine cancer, but there are things you can do. So women that have used birth control pills for about 5 to 10 years during their life decrease their chance of endometrial cancer by about 50%. Maintain a healthy weight. Don't get overweight. If you're overweight, your fat cells are making estrogen, and that can turn your uterus into cancer. And if you are taking estrogen and you have a uterus, take progesterone. The surgical options are pretty much the same. Radiation in certain stages. If you have precancer cells of the uterus, depending on which type of precancer, we can actually treat that with pills, and that will reverse it. There's also chemotherapy and surgery. Everybody with endometrial cancer is going to end up with a hysterectomy because that's the only way to know if you need further treatment. So let's talk about ovarian cancer. And this is the scariest one because we have no screening for ovarian cancer. There's nothing out there like a mammogram or a pap smear to tell us that you have ovarian cancer. And usually by the time people present with ovarian cancer and we figure out that they have it, they're already stage 3 or stage 4, which is worse. Almost always in older women. About 10% of cancer of the ovary is genetic, 90% is not. So if you have a strong family history of breast cancer or cancer of the ovary, we need to test you for this BRCA1 or 2, and that stands for the breast cancer 1 gene. But even though it's the breast cancer gene, it's highly associated with ovarian cancer. So if you've had a breast, uterine, or colorectal cancer, it puts you at higher risk. Certain subpopulation, like an Ashkenazi Jewish population, Eastern European background, they're at higher risk. And if you've had endometriosis, which people have had when they're younger, where they have lots of pain and bleeding in their pelvis, or if they've never given birth or had trouble getting pregnant, that does slightly increase your risk. So here's the problem with ovarian cancer. The symptoms that people have are very nonspecific, which means that these symptoms can be caused by 900 other things that are not ovarian cancer. So belly pain, back pain, feeling bloated all the time, feeling like every time you eat, you just get full very quickly. I will tell you that this one here, the bloating and the feeling full while eating, everybody with ovarian cancer is going to have this symptom, but the vast majority of people that have these two symptoms don't have ovarian cancer. But if you have 6 weeks straight, continuous, not on and off, but continuous feelings of bloating and getting full quickly, then you should be evaluated by your gynecologist. So again, treatment. These people tend to present at a later stage. So they're usually getting radiation and chemotherapy. They will all need surgery. But again, breast cancer and cancer of the uterus typically presents at stage 1, whereas ovarian cancer typically presents at stage 3. So it's harder to treat. Let's talk a little bit about menopause. So the definition of menopause are no periods for a year. When your ovaries stop making eggs, then you stop making estrogen. And when your ovaries have stopped making estrogen for a year, and you haven't had a period, you are by definition menopausal. The average age is 51. Everybody's menopause is different. I have some women that go through it, have no symptoms. I have some women that go through it for 15 years. I have some women that go through it for 3 years, it goes away in terms of hot flashes, then comes back. The main symptoms are hot flashes and night sweats, vaginal dryness, or pain with intercourse. We're going to talk about the treatments of these. So, it's a lot of misinformation about treatment of menopause. There are two key distinctions in terms of risks. Do you have a uterus or do you not? Remember before, for endometrial cancer, if you have a uterus and I give you estrogen and no progesterone, you can get endometrial cancer. So if we're going to treat you for hot flashes and night sweats, and you have a uterus, you have to have both estrogen and progesterone. There's some risk to that, and I'll talk to you about that. And there also is a different way to give estrogen. One is by mouth, and one is through the skin or transdermal, like a patch. You take it by mouth, it does slightly increase your risk for stroke. If you use the patch, it doesn't. So I try to get all my women, if we're going to do hormones, a patch for the estrogen and a progesterone for the pill. Now, if you don't have the uterus, we don't have to worry about the progesterone. You can just take estrogen only. The other distinction is, are you having symptoms that are systemic, which means that they're all over? So are you having the hot flashes and the night sweats? Or do you just have vaginal symptoms or local symptoms, the vaginal dryness and pain? The only way to fix hot flashes is to give you estrogen to your whole body. So that's how we do it with the pills or the patch. If your main complaint is just vaginal dryness or pain with intercourse, we can treat that with these things down here at the bottom with essentially no risk. So vaginal estrogen cream, another type of cream called DHEA, or a pill called Asthena. So I want to talk about the risks. So this is what people worry about it. And I worry when people go on Google and they read, oh, it causes this cancer, it causes that. And people don't really get the full information. So if you are taking estrogen and progesterone together and you're older, so over the age of maybe 55 to 60, it does slightly increase your risk of breast cancer. Out of 10,000 women in a year, 8 extra women would get breast cancer. So it does increase your risk, but it's not very high. It does increase your risk for stroke and a blood clot in your leg. Now, the interesting thing is if you take the estrogen only, there was no increased risk of breast cancer. So if you don't have a uterus and we can do estrogen only, and we do it through the skin, we don't have the risk of stroke or blood clot, and we don't have the risk of breast cancer. So a lot of people don't know about this part. They just assume all hormones cause cancer, but that's not necessarily true. Now, if we're just treating locally, so just the vagina because of dryness or pain, there's really no significant risk to this. Vaginal estrogen only goes to the vagina, doesn't go to the rest of your body. DHEA, which is another type of cream, no significant risk. The Asthena is a pill, very well tolerated, but there is a very, very, very low risk of a blood clot. But all of these three can fix the vaginal symptoms without increasing your risk for stroke or breast cancer. So this is kind of a pet peeve of mine. You will hear about bioidentical hormones. And what you see out there are lots of different physicians or even nurse practitioners who are prescribing these medicines. And in my mind, it is doing a huge disservice to the community. So when we talk about menopause, we are not treating a lab value. We are treating a symptom. We don't need to measure your hormone levels because it doesn't matter. The only thing that matters are your symptoms. If you're having hot flashes, I want to make them go away. I don't need to make your estrogen levels normal to what they were when you were 30. I just need to make your symptoms go away because there are risks to higher doses of the medicine. So this here I want to read to you. The American College of OBGYN, so when you're board certified like myself, this is who board certifies you. This is their statement. Evidence is lacking to support superiority claims. So bioidentical hormones do not work better and are not necessarily better for you than the FDA-approved ones. These customized hormones pose additional risk because there's over and under dosage. So people are testing these lab values that are not accurate. They're then concocting a recipe for you, and there's a high chance you're going to get too much estrogen and not enough progesterone, then you end up with cancer. So I have seen people with precancer and cancer from bioidentical hormones. So there is no evidence to support increased effectiveness. ACOG has come out, and every major professional organization said do not do. Why these other physicians and nurse practitioners are doing it, I don't know. It does cost a lot of money, so I worry about conflict of interest with that. But this is a big no-no. So let's finish up with urinary incontinence. This is a very, very, very common thing that we see here in the villages, but nobody talks about it. The key thing to remember is there's two types of urinary incontinence. It's called stress incontinence and urge incontinence. When I say incontinence, most people think of the top one. And what stress incontinence is when you cough, you sneeze, you put pressure on the bladder. It's a physics problem. You're putting more pressure on the bladder than the bladder can hold, and you leak. Urge incontinence is distinctly different. This is, I gotta go, and I can't get there. So that they are two separate types of incontinence, and they are treated completely differently. So stress incontinence is a weakness in the muscles of the pelvic floor. It's a weakness of the bladder. So you can do the Kegels. That will help. If you strengthen those pelvic floor muscles, it will help. But if you have the other type of incontinence, it won't. Vaginal estrogen will help. Most people laugh when I say this, but go into rehab, what we call pelvic floor rehabilitation, actually really works. Just like if you had a tear to your shoulder muscle, the rotator cuff, you would get it fixed. You would go to physical therapy. They would help you strengthen the muscle. There are a couple ladies that over at Lake Rehab that do a fantastic job at pelvic floor rehab and really helps. Now, urge incontinence we treat differently because there's a whole different reason why it occurs. What's happening here is your bladder's contracting when you don't want to, makes you feel like you have to go, and then it squeezes and you leak. So doing bladder retraining really works. Just like when you're a little girl and your mom or dad taught you how to pee-pee in the potty, you can retrain your bladder. Vaginal estrogen works. There are lots of different medicines out here. There's one called oxybutynin, Myrbetrix, or Vesicare, and those help relax the bladder. For harder cases, there are two other things a little bit more invasive. So there's something called PTNS, and that stands for posterior tibial nerve stimulation. So what that is you have a little nerve behind your ankle bone, and we can stimulate that nerve, which runs all the way back to the bladder, and it kind of resets the bladder so it stops contracting. The other thing, in the worst cases, is what's called bladder Botox. You may have heard of Botox for wrinkles, kind of cosmetic things. What Botox does is it paralyzes, to a certain degree, muscles. So we can actually inject that into your bladder to help relax it. So stress incontinence is different than urge incontinence. And surgically, you can fix stress incontinence, but urge incontinence, you do not fix surgically. You fix with medicines or one of these two things down here. That's actually the end of the information I have.